Parasympathomimetics, these are drugs which produce action similar to parasympathetic stimulation, or more accurately, these are drugs which stimulate muscarinic receptors. They are called muscarinic agonists. Muscarinic agonists can be classified into either direct acting on receptors or indirect by inhibiting cholinesterase. Direct acting, for example, acetylcholine, and indirect, they inhibit cholinesterase enzyme, allowing accumulation of acetylcholine to act on muscarinic receptors. These drugs have muscarinic action, and muscarinic action include effect on eye. They produce meiosis through stimulation of muscarinic receptors in constricted pupillary muscle, contraction of ciliary muscle, and this will accommodate eye for near vision. Meiosis and contraction of ciliary muscle will increase aqueous drainage, and this will decrease intraocular pressure. Also, they produce lacrimation and conjunctival congestion. They increase all secretions: lacrimal, salivary, bronchial, gastrointestinal, and sweat secretion. On bronchi, they produce bronchospasm, bronchoconstriction. On cardiovascular, they decrease heart rate, decrease EV conduction, and produce hypotension. On GIT, they increase secretion and motility. Urinary, they contract wall and relax sphincter, inducing micturition. All these are called muscarinic effects or muscarinic actions. Some of these drugs act also on nicotinic receptors. And nicotinic actions include nicotinic receptors in neuromuscular junction, inducing muscle twitches, autonomic ganglia, and adrenal medulla. We have also nicotinic receptors. If we are recording blood pressure and then we give acetylcholine in small dose, it will produce hypotension due to stimulation of muscarinic receptors. If these muscarinic receptors are blocked by atropine, then we give acetylcholine again in the same previous dose. It has no effect because the receptor is already blocked. But if we give acetylcholine in a large dose, it will act on nicotinic receptors which are present in adrenal medulla and sympathetic ganglia, releasing adrenaline and noradrenaline. This will produce hypertension. So acetylcholine, when given a small dose, it produces hypotension through its muscarinic action. After atropine, it produces hypertension due to its nicotinic action. This is called acetylcholine reversal by atropine. It occurs with drugs having muscarinic and nicotinic action. Parasympathomimetics, we have direct acting, including choline esters, Cholinomimetic Alkaloids, and indirect acting anticholinesterases, which are either reversible or irreversible. We start by choline esters. They are direct acting. They are quaternary ammonium compounds, so they are ionized, lipid insoluble. They cannot cross blood-brain barrier, and they are distributed extracellular. Choline esters include acetylcholine, methylcholine, carbochol, and methylcholine. Acetylcholine is natural, but methylcholine, carbochol, and methylcholine are synthetic. Start by acetylcholine. It is metabolized by cholinesterase. We have two types of cholinesterase, true and false. Acetylcholine is characterized by both true and false. It is not effective orally. Of course, it has muscarinic and nicotinic actions, and it is non-selective. It has no therapeutic use due to multiple actions and very short duration. Methylcholine is synthetic. It is hydrolyzed by true cholinesterase only. Oral absorption is irregular, so When given orally, you have to give larger dose than given parenterally. It has muscarinic action and insignificant nicotinic action, selectivity mainly on cardiovascular system. It may be used for treatment of paroxysmal atrial tachycardia, or sometimes it is used for diagnosis of bronchial asthma. Carbachol, it is synthetic, it is not affected by cholinesterases. Oral absorption is almost complete. It has muscarinic and nicotinic action. Selectivity mainly on eye, some extent GIT and urinary. It could be used in treatment of glaucoma. Ethanicol is synthetic. It is not affected by cholinesterase. Oral absorption is complete. It has muscarinic actions only. It has nicotinic action. Selectivity mainly on GIT and urinary, so it is used in treatment of paretic ileus and non-obstructive urinary retention. These drugs are given. Acetylcholine, of course, when previously used, is given intravenously. Methacholine is usually given subcutaneously. Carbachol and ethanicol are given oral or subcutaneous, and these drugs should never be given IV. Otherwise, they will produce severe hypotension and marked bradycardia. Choline esters are contraindicated in bronchial asthma, peptic ulcer, coronary insufficiency, hypotension, and bradycardia, and never given intramuscular or intravenously. They will produce severe bradycardia and hypotension, which can be treated or antagonized by atropine. Cholinomimetic alkaloids include pilocarpine. This alkaloid, derived from plant origin, could be absorbed orally, distributed all over the body. It is a tertiary ammonium compound, so it crosses blood-brain barrier. It is not affected by cholinesterase and it acts direct on muscarinic receptors. Marked action on eye and exocrine glands. So it could be used in treatment of glaucoma, eye drops in treatment of glaucoma, and to antagonize the effect of mediatics, which are used for fundus examination. It could be used also as a silagogue to increase salivation in treatment of dry mouth, which is Edrophonium. And it could be used as a diaphoretic to increase sweating in treatment of fever, and it can be applied topically on scalp to increase hair growth. Now, what about indirect acting anticholinesterases? They inhibit cholinesterase enzyme, and this will accumulate acetylcholine to act on muscarinic and the nicotinic receptors. So, anticholinesterases must have muscarinic and the nicotinic actions. Their inhibiting effect on enzyme may be reversible or irreversible. We start by reversible anticholinesterases. Physostigmine and neostigmine. Physostigmine is natural. It is derived from plant origin. It is a tertiary ammonium compound, so it is non-ionized, it is lipid soluble, it can cross blood-brain barrier. Neostigmine is synthetic. It is a quaternary ammonium compound, so it cannot cross blood-brain barrier. Physostigmine could be absorbed orally. Of course, it passes to brain, duration is short. Neostigmine oral absorption is incomplete. It cannot cross blood-brain barrier. It has a longer duration than physostigmine. What about actions? Physostigmine has muscarinic and nicotinic actions and CNS stimulation. It can produce CNS stimulation inducing convulsions. Neostigmine has muscarinic actions, nicotinic actions, and it has a direct skeletal muscle stimulant effect. But of course, it has no effect on CNS. Physostigmine is used locally on eye to produce meiosis and decreases intraocular pressure for treatment of glaucoma and to counteract the effect of mydriatics. The only indication systemically is in treatment of atropine poisoning. It could not be used in treatment of urinary retention or paretic ileus because it crosses the blood-brain barrier inducing convulsions. Neostigmine, it is used for diagnosis and treatment of myasthenia gravis. It could be used to antagonize the action of choline, which is a neuromuscular blocker, which blocks nicotinic receptors in skeletal muscles. And in these two situations, give atropine before to block its muscarinic actions. It could be used in treatment of paretic ileus, non-obstructive urinary retention, and treatment of paroxysmal atrial tachycardia. It could be used also in treatment of atropine poisoning, but here it will antagonize only peripheral actions of atropine, but it cannot antagonize central axis. Edrophonium is short-acting reversible anticholinesterases. It is a synthetic quaternary ammonium compound, so it has no action in CNS. Duration is about 2 to 5 minutes due to rapid renal excretion. It is not substrate for cholinesterase enzyme. It is excreted unchanged in urine and of course is given intravenously. It is used for diagnosis of myasthenia gravis. And it could be used also to differentiate between cholinergic crisis and myasthenic crisis. What about irreversible anticholinesterases? They are called organophosphorus compounds or organophosphate compounds. They are non-competitive irreversible inhibitors for cholinesterases. Most of them are highly liposoluble, except eicosapent, so they can be absorbed from any site, including intact skin. What about poisoning? Poisoning is due to these drugs are highly toxic, and toxicity may occur due to inhalation of spray or dust of insecticides, contamination of skin, contamination of food, or suicide. Symptoms of poisoning include exaggerated muscarinic actions, bradycardia, hypotension, vomiting, colic, diarrhea, bronchospasm, meiosis, and increased oral secretions. Nicotinic, muscle twitches, and excessive acetylcholine at neuromuscular junction will reduce depolarization block, neuromuscular blocking effect of diaphragm and intercostal muscles. CNS, restlessness, insomnia, confusion, convulsions, coma, depression of respiratory center and the vasomotor center. So cause of death is respiratory failure, which may be peripheral or central or both. Treatment of organophosphorus poisoning. Antidote is atropine. Atropine is given intramuscular or intravenously every 10 minutes until pupil dilates and secretions dry and heart rate increase. It antagonizes muscarinic effects, central and peripheral. Cholinesterase enzyme reactivator, they are called oximes, including pyridoxine and diacetylmonoxime. They combine with poison in blood and may dephosphorate the enzyme if given early before aging of the enzyme. They reverse muscle weakness and are used with atropine. Pyridoxine cannot pass to CNS, but diacetylmonoxime it can cross blood-brain barrier. Care of respiration by artificial respiration and suction of secretions. Anticonvulsant drugs as diazepam, barbiturates, or magnesium sulfate injection. Stomach wash if taken orally and remove of contaminated causes. Remove the remnant of poisoning which are present on skin. Washing of skin with sodium bicarbonate.